Hello friends, now I will be talking to you about sickle cell anemia. It is a autosomal recessive disorder and the basic problem is in the point mutation in the gene which is responsible for globin chain synthesis, and it is a qualitative defect. Remember, in thalassemia also there is a problem of globin chain synthesis, but that is a quantitative, and here it is qualitative defect is there. Now what is the problem? We have a hemoglobin S in the beta chain, in the 6th position glutamate is replaced by valine. Similarly, we have one more hemoglobin C, again in the beta chain, in the 6th position glutamate is replaced by lysine. And we have a HBE where in the beta chain, in the 26th position glutamate is being replaced by again lysine. So what you can see, everywhere it is a glutamate which is being replaced by either valine or lysine, but even the chain involved is again beta chain. Now it may be homozygous. In homozygous we write as HB, SS, or it may be heterozygous, we write as HBAS. As far as heterozygous are concerned, they are resistant to Plasmodium falciparum. Okay, and 10% of the blacks, they usually have a heterozygous type of sickle cell anemia. Now, what is the pathophysiology? Pathophysiology. That is homozygous sickle cell, HB, this one, HBSS. So, sickle cell, it is any condition which lead to hypoxia, or when it is deoxygenated hemoglobin, and these hemoglobin they get aggregated and they polymerize, and once the hemoglobin has been polymerized, so RBC assumes a sickle shape. Sickle shape is like this. Okay. Now what are the factors which can precipitate this sickling? The precipitating factor are, first of all, hypoxia. So patient going to high altitude, they are more likely to suffer from all these problems. Anything which lead to dehydration, that's why sickle cell patients should always keep them hydrated, and they should always avoid going to very high hilly areas. Acidosis, that's why it is very common in diabetic patient having DKA. Sickling is very common because sickling itself is not only precipitated by acidosis, but in DKA marked dehydration is also there, and very high grade fever or very cold temperature also precipitate sickling. Now what is the outcome of this sickling? As they are shaped distorted, so outcome is they have extravascular hemolytic anemia, but point to be noted, it is intrinsic defect. Second thing is stickiness, increased stickiness. What happened is that this is the blood vessel and these are the sickle cells. they tend to adhere to each other. They are more sticky to each other. As they become more sticky, they are going to block the microcirculation. So, due to blockage of microcirculation, there can be ischemia or infarct of any organ in the body. So, let us see how patient come to us. Patient may come with the acute, clinical feature may be acute or chronic. In the acute, because of increased stickiness, patient may have mesenteric infarct, and that lead to severe pain abdomen. It lead to severe patient may have transient ischemic attack, myocardial infarction, renal papillary necrosis, this also lead to severe pain in the loins. Blindness can occur. Spontaneous abortion can occur due to placental infarction. Priapism, it is a painful erection of the male genitalia. This is due to prostatic venous plexus infarction. Acute chest syndrome. In this, patient has severe pain chest. Fever, shortness of breath, breathing difficulty, hypoxia. And why it happened? It happened either due to pneumonia. Pneumonia could be due to streptococcus or viral, or it could be mycoplasma, or second is it could be bony infarct. Bony infarct. Okay. So, in acute chest syndrome, if you take the chest X-ray, you get infiltrates, you get lot of and acute chest syndrome is the most common cause of death in young adults or young people. The next problem is dactylitis. This dactylitis is also known as hand-foot syndrome. This is classically seen in children between 6 months to 2 years, and it is uncommon after the age of 2 years. And what happened in this thing? There is swelling in the fingers or toes, and there may be infarction of metacarpals and metatarsals. Then the next problem what patient can come with the acute problem is osteomyelitis. This is classically salmonella osteomyelitis. Patient may have septic arthritis, and this septic arthritis is due to staphylococcus. So in that way we can say patients are prone to infection, maybe in the bone, maybe lungs or anywhere else also. Now not only patient can have acute presentation, patient also have chronic presentation, anemia, because of why? Extravascular hemolytic anemia, and of course since there are no autoantibody are involved, it's a type of Coombs negative hemolytic anemia. Gallstone, and they are usually pigment gallstone. Ulcers are very common in the leg areas. Leg ulcers are very common in these patients. Patient may have autosplenectomy because of repeated infarction in the spleen. So usually in a child above 10 years in sickle cell, spleen is not palpable. But one thing is very, you should be very cautious about it. Here we have an extravascular hemolytic anemia. Most of the conditions where we have extravascular hemolytic anemia, like hereditary spherocytosis, spleen is palpable, but this is an exception where spleen is not palpable. Now there are few conditions where there can be sudden fall of hemoglobin occurs, and there are two important reasons for that. One is aplastic crisis, and this is very common after parvovirus infection, and in this condition retic count is reduced. Other is sequestration crisis. Here the retic count is normal or increase. Okay. Now let's see how to investigate this case. The best initial test is peripheral blood film. In the peripheral blood film, of course, we see sickle cells, which are very obvious, like this, what I already told you. We can also see Howell Jolly bodies. These are nuclear fragmentation. Nuclear chromatin fragmentation. And for the initial screening tests, we can go for sodium metabisulfite for screening. What it is done, that a drop is put in the slide of sodium metabisulfite, and it creates hypoxia, and hypoxia induces sickling. So it's a screening test. But most confirmatory test is hemoglobin electrophoresis. What we get in trait, that is HBAS, you get HBS about 40 to 45%, and HbA, hemoglobin A, you get 55 to 65%. Point to be noted that in this HbS concentration doesn't go above 45 or 50%. That's why in these patients, normally patient doesn't have much feature of any of these features what I mentioned for sickle cell are not there. Because to have the feature of sickle cell, the HbS concentration should be above 60%. That's why those who are those who are trait, they do not have much of the manifestation. But in sickle cell, HbS is 90 to 95% and HbF is 5 to 10%. That's why they have lot of manifestation. But one thing point to note it, in these patients there is no HbA. There is no adult hemoglobin. HbF is there in 5 to 10% case in the percentage wise. What else we get it? In CBC, complete blood count, increased TLC and increased platelet, P for platelet count. Thrombocytosis is there. And what we get in X-ray? If you do the X-ray of vertebra, you get fish mouth vertebra. And if you do the X-ray of the lateral view of skull, you get hair on end appearance. For prenatal diagnosis, you have to go for fetal DNA analysis and you look for the point mutation. Now, how to treat a case of sickle cell? Patient come with any painful crisis, so you have to use opioids. We have to maintain the good hydration. Folic acid should be given regularly because they have a lot of hemolysis going on. Infection should be treated because these patients are prone to various infections I discussed. And of course, in severe anemia, we may have to go for blood transfusion. We use hydroxyurea. The purpose of hydroxyurea, it increases HbF level. And HbF resists sickling. So we want more and more HbF should be there so that sickling is reduced. Now, sickle cell trait. All these what we discussed was for sickle cell anemia. Sickle cell trait, what we have learned that in sickle cell trait, HbS is 40 to 45%, A is 50 to 55 to 65%. And just to remind you, these patients are resistant to Plasmodium falciparum infection. This we have studied earlier. Now, they are heterozygous. The peripheral blood film is normal, point to be noted. Clinically, there is no anemia. But then what the problem they have? They usually have problem in the kidney, renal problem. What the problem is? First of all, decrease ability of the tubules to concentrate the urine. That's why they have a fixed specific gravity of the urine, what we call as isothinuria. These patients may have sometime hematuria and they have a recurrent UTI is the problem. So these patients, they have more of a renal problem rather than the hematological problem. Okay, so this is all about sickle cell anemia. Thank you very much.